Hello and welcome back to the Bedside Murmurs podcast, a podcast where we chat with doctors about the careers, pathways in medicine, clinical tips, and much more. If you have any questions or any ideas for guests you would like to see on the show, please send us an email at podcast@medsoc.org.au or direct message us on Instagram at Bedside Murmurs. I'm Sean.
And I'm Emily, and we will be your hosts. Today, we have the pleasure of speaking with Professor Michael Kidd, who is a Professor of Global Primary Care and Future Health Systems at the University of Oxford and the University of New South Wales. Professor Kidd served as Deputy Chief Medical Officer and Principal Medical Advisor with the Department of Health and Aged Care during the COVID-19 pandemic and has recently been appointed as Australia's new Chief Medical Officer. Professor Kidd has wide-ranging and extensive experiences as a general practitioner, primary care researcher and academic, and has served as the President of the World Organisation of Family Doctors and the President of the Royal Australian College of General Practitioners. Welcome, Professor Kidd, to Bedside Murmurs. It's wonderful to have you here with us today.
Thanks, Emily. Thanks, Sean. It's great to be here.
You've had a very illustrious medical career, but let's start at the beginning. Where did you go to medical school and what was that like?
Okay, so don't hold it against me, but I'm from Victoria and I went to medical school at the University of Melbourne. And that was an amazing experience. I think the biggest challenge I faced when I started in medical school was that I was the only person from my high school who went into medicine. And I was used to being quite clever and near the top of the class. And all of a sudden I arrived in medical school and I found that everybody was clever and everybody had been top of the class. And it was quite a challenge. And but also once I got over that, I learned a huge amount from my peers, the other medical students, and I just loved every aspect of the medical training.
And what were some of those experiences that you had in medical school, and did they influence your decision to become a general practitioner?
Yeah, so in those days, I started medical school in 1978, so you can kind of work out how old I am now. And in those days, you did 3 years of preclinical medicine where you didn't see a patient for all 3 years, and then 3 years of clinical medicine. And most of that was in the hospital system. I was based at the Royal Melbourne Hospital. But as part of the training, we did an attachment in general practice. And I was very lucky. I went and did my GP attachment in a semi-rural area with a wonderful elderly general practitioner who was famous because in 1942 he had won the Brownlow Medal. So he was a football player. His name was Don Cordner. And Dr. Don, as all his patients called him, had a lot of very elderly patients, and he spent most of his day in his car driving around doing home visits and visiting his patients in their homes, which were largely on farms and in small rural villages. And a lot of the work that he did was actually palliative care. He was looking after people who were dying, and he was supporting them so they could die in their own homes. And I just watched this amazing general practitioner and watched what an impact that he had on the community where he worked and how much his patients loved and respected and trusted him, and how well he worked with other healthcare providers, particularly the palliative care nurses and others in the team. And I thought, wow, I think when I grow up, I'd like to be a doctor like Dr. Don.
And what was your experience going into general practice?
So, I graduated from medical school, and like many of us, I wasn't quite sure which specialty I wanted to train in. So I kept my options very broad, and I did a year of general adult medicine. I did a year of pediatrics. I did 6 months of obstetrics and gynecology. I did 6 months of psychiatry. And woven within this, I did attachments in general practice with some city practices and some rural practices. And, I loved every specialty that I got my hands on. And, it was obvious that the specialty where I could bring in all of those different areas was general practice. So I enrolled in the then general practice training program. And when I finished my training and attained my fellowship of the Royal Australian College of General Practitioners, I then looked around to decide where was I going to set up my own practice. And this was in the later part of the 1980s, and the HIV/AIDS pandemic had begun a few years earlier. And as a gay man, I'd seen friends who had been infected with HIV. Some had died from HIV, and I'd also seen, to our shame, that there were doctors and part of our healthcare system which actually discriminated against people with HIV or people who are felt to be at risk of HIV. So I thought, this is probably the area that I want to spend my time. So I joined the Gay Men's Health Centre, which was a clinic set up within the Victorian AIDS Council in Melbourne, and started working as a GP predominantly with people either with HIV or people who were concerned about the risks of HIV. And the clinic that I worked in was a community-based clinic. It was multidisciplinary. We had GPs, we had consultant specialists in different areas, we had counsellors, we had wonderful primary care nurses, we had a massage therapist, an acupuncturist, a whole range of different health professionals working together, and a whole army of community volunteers who were helping to provide care to the young people who we had in our practice who were very sadly dying of HIV/AIDS at that time. And this was before the effective treatments became available in 1995, 1996. So all of our patients with HIV/AIDS we expected were going to die, and indeed each year we had a group of people who were being cared for in their own homes and getting shared care with the hospitals, and we were looking after them. So it was incredibly challenging general practice work, but also very rewarding work. And as by chance, it also exposed me to infectious diseases and a pandemic, being the HIV/AIDS pandemic, and that experience would come into use later in my career.
It sounds like you really enjoyed working as a general practitioner and that you found a lot of satisfaction doing general practice. But how did you become involved in general practice research and governance?
Yes, so I was fortunate when I was doing my postgraduate general practice training that in the last 2 years I was awarded an academic general practice registrar post, and that was at Monash University, the other medical school at the time in Melbourne. And through that post, I learned about health and medical research. I learned about medical education, and I started to get involved with my college, the RACGP, and enjoyed all that as well. So I was getting this mix of clinical work and academic work, and started doing research. I did my research doctorate at Monash, and that focused on particularly on the use of new technologies in healthcare, digital health, if you like, but in those days we didn't call it digital health, and particularly looking at electronic medical records in general practices, which were just starting to be introduced. We had, in those days, the data was on what were called floppy disks, which were literally big black floppy disks, and you put one in with the program and one in with the data. And what we were looking at was whether we could use these newfangled electronic medical records to improve the quality and the safety of the care that we were providing to our patients. So we're doing some early research there, which was really exciting.
You've had numerous roles in general practice leadership, most especially as the president of the Royal Australian College of General Practitioners. How has your vision for general practice matured through your experiences serving as for the general practice community?
Yes, so it's a great privilege being elected by your peers to become the president of one of the Royal Medical Colleges here in Australia, and many of the colleges are also Australia and New Zealand colleges, but the RACGP is just Australia, and New Zealand has its own wonderful college of general practitioners as well. One of the things about being involved with the college is you get the opportunity to meet with your peers, to look at different areas of current contemporary issues, which are challenges in general practice. I was particularly interested in looking at how to improve the quality of the care we provide. I was interested in the medical education that we were providing to general practitioners after they'd graduated, and I was interested in the area of general practice and primary care research and how we could particularly look at computerised medical records as a source of information and data to help us to better understand what was happening in general practice and use that data for clinical research as well. So learned a lot of things, but one of the other opportunities that I had was to represent the college in meetings with the government and particularly with the Australian Government Department of Health and Aged Care, because as you probably know, general practice is funded by the Commonwealth in Australia through the Medicare benefit schedule, unlike our public hospitals, which are funded through each of the states and territories. So I started on this journey of going to Canberra and meeting with the policymakers and providing advice about what was happening in general practice and providing advice to the policy development. And I guess, now 30 years later, I'm still doing the same.
Now that you have continued to work with the government, you were the Deputy Chief Medical Officer in 2020 to 2023, which our listeners would realise was during the start and the height of the COVID-19 pandemic. What was it like being in this role during the COVID pandemic?
Yeah, being in a role like that at a time like that in our nation's history was probably the greatest privilege of my medical career, and I was very conscious that the advice that I was providing, it was really important that it was good, well-founded advice, where possible, based on evidence. Although, of course, when COVID-19 first appeared, it was a new infectious disease, and we started learning about who was most impacted by the infectious agent and ways that we could protect people. So knowledge accumulated over time, and we learned from colleagues in other countries as well as the experience that we had around Australia. I had a few areas of particular responsibility. I was responsible for aspects of the primary care response to COVID-19, so recognising that people were being infected in the community, that they were likely to present to their local general practitioner or to their local pharmacist or to emergency departments. And so we're looking at how to protect the people who are working in those settings. We're looking at the way to respond. We set up a number of general practice respiratory clinics across the country where if people had respiratory symptoms, instead of going to a regular general practice and putting other patients at risk, they could go to one of these special clinics and be assessed to see if they had COVID-19 or something else that was causing their respiratory symptoms. We did a lot of education of healthcare workers. I also chaired the aged care advisory group for the Commonwealth. So as you may recall, the people who were at greatest risk of serious illness and risk of death from COVID-19 were particularly elderly people and people who were living in residential aged care facilities were at increased risk because there were large numbers of people living in many of these facilities, as we saw in the early stages, but also people with chronic health conditions, people who are immune compromised were at risk as well. I was also involved in the rollout of telehealth, so my digital health interests were there as well, and this was really interesting. We had a 10-year plan for reforming primary care in Australia, and the plan was over 10 years to introduce telehealth into general practice and other parts of healthcare as part of the Medicare benefit schedule. And what we ended up doing was, rather than taking 10 years to do that, we actually took 10 days to do it, because as we moved towards going into that first period of lockdown, what we knew was essential was that people would still be able to contact and consult with their trusted GPs and other medical consultants, and so the telehealth system was set up in record speed, and of course now has become an enduring part of our healthcare system.
Yeah, the COVID-19 pandemic was such an accelerator for digital health technology in Australia and all across the world. How do you think Australia navigated the COVID pandemic compared to other countries? And what has our healthcare system learned from this experience?
Well, I, of course, have a very biased view about that, but what do you think? How do you think we did?
Oh,
As someone who used to watch the television every morning looking for updates, I think I really appreciated how honest and clear medical officers were, and that it was based on solid evidence. But also, if medical officers weren't sure about what was happening, it would be transparent. It wasn't as if anything was trying to be hidden. It was just very clear. This is what we know so far. We're going to do our very best to move forward. And actually, the coordinated response, I think, is something that is a testament to, the strength of our healthcare system and organizations, because many other countries, I presume, didn't have the same frameworks and structures that we're blessed to have in Australia.
I also think because of geography of Australia and like the demographic, like in terms of how many people there are in population density, we got very lucky during the pandemic because a lot of the countries, especially up in Asia and also across America, there was really fast and rapid spread across Britain as well. But in Australia, I think because we are like
We are an island.
kind of like an isolated part of the world, we could much better coordinate with the quarantine procedures. And also, it just meant that the spread of the virus was a little bit lower and slower than in other countries, which gave us time to reflect on more evidence, perhaps having a little bit better of an idea of what the virus was and how to best contain it from the mistakes and the things that we've learned from other countries as well.
Yeah, I think they're both really, really good reflections. You know, you're quite right. Where we were fortunate that COVID-19 first appeared in China, in Wuhan, and you know, I think we all watched in horror, really, at what was happening in Wuhan, and then watched how it was transmitting to other parts of China, and then to Hong Kong, to North Korea, to Iran, and then we saw the hospitals being overwhelmed in Italy early in the pandemic. And so one of the important approaches was to make sure that we did not have our health system overwhelmed as a consequence of the virus running rampant through the population, because we saw that happen in other parts of the world. I think you saw that in Europe, you saw that in North America, you saw it in many parts of the world. Australia made a decision early on to close the borders, and so to reduce the introduction of COVID-19 into Australia, and to buy some time to build capacity, particularly in intensive care and support for people who became seriously unwell, to build capacity in our public health units across the country. I think Australia was also fortunate because we do have a very strong healthcare system and we have very strong primary care, and a lot of the public health response relied on strong primary care. And you could see this as we were doing testing and treatment, as we set up the community-based assessment centres. When the vaccines rolled out, the majority of vaccines were administered through general practices and then through community pharmacies. So, you know, we use the infrastructure which we have here in Australia, and I think, you know, the other side that we need to be aware of is that the population in Australia, by and large, were incredibly responsible. And people listened to the advice. You know, I did those early morning breakfast programs and the midday updates throughout 2020 and into 2021, and people listened to the advice. I think people appreciated that that we didn't know everything all at once, and that some of the advice needed to change as the evidence became more clear about what was happening, and so that response was good as well. And when we had the vaccine become available, at the start of 2021, people were extraordinary in turning up and getting vaccinated and recognising that they were not only protecting their own health and well-being, but they were also protecting the health and well-being of other people, and particularly those who might be at greatest risk if they were to contract COVID-19.
And as during COVID, you were also appointed as the director of the Collaborating Centre on Family Medicine and Primary Care with the World Health Organization. What does this role involve, and how have you seen primary care provision change globally as a result of COVID?
So that actually became the emeritus director in 2020, but I had been the director and had established that centre in 2017. And at the time, I wasn't working in Australia; I was working in Canada.
Oh, wow.
At the University of Toronto, and we worked with the World Health Organization in Geneva to establish this new collaborating centre on family medicine and primary care. And in particular, through that centre, what we were looking at was how to work with governments to strengthen their primary care systems, and particularly in order to ensure that everybody in a country, no matter whether they're poor or rich, no matter whether they live in cities or in regional or rural or remote locations, no matter whether they're old or young, whoever they are can get access to high quality healthcare delivered by well-trained primary care clinicians.
So how does primary care, through your experience, differ in its implementation across different countries? What kind of considerations do you have to put behind suggestions for primary care models? And what can the Australian primary care model learn from other countries' implementations?
Yes, so primary care is, if you like, community-based healthcare. We describe it as being first contact care, so the first place that people will go seeking medical health or advice. It's also a place where you get known by your individual general practitioner or the primary care nurse, community health worker in the different settings where you're working. So you have continuity of care over time. There's also comprehensive care in that all the specialties all come together, which is what a good general practitioner does. And there's also coordination of care. So being able to refer people and get information back to understand the whole person rather than a specific type of disease that a person may have or a specific body part. You understand the whole person and also that person in the context of their family and the community where they live. So this is primary care. We've been talking about primary care and primary health care for many years, since the declaration of Alma Ata in the 1970s, before I started training at medical school. And over recent years, there's been a particular focus globally on looking at ways that we can strengthen primary care to ensure that everybody can get access to healthcare services as a way of ensuring universal health coverage, which is what the WHO and the United Nations describe with everybody having access to healthcare, recognising that access to healthcare is one of those fundamental human rights, but that there are many people in different countries across our planet who are still missing out on access to basic healthcare and the sort of healthcare that in countries like Australia we take for granted. Now, Australia has a very good health system. We had a recent survey released by the Commonwealth Fund in New York, which ranked 10 of the most high-income countries and their healthcare systems, and Australia came number one. Australia won the gold medal. We medalled and did very well, but there were still areas where other countries were doing better than we were. So we can learn from each other about how to improve access, how to improve equity, how to deliver healthcare in ways which are cost efficient and deliver people the care they need, how to bring together teams of health professionals to work together to deliver that comprehensive care to the individual. One GP may not know everything there is to know and can benefit from other consultant doctors, from nurses working in primary care, from colleagues in allied health, from physiotherapy, dietetics, optometry, you name it, who can all come together and provide a better health experience for each individual patient.
You've been very well placed to learn from different institutions across the globe about what global primary care looks like and how we can be moving forward. What do you think that you've learned from the different countries and communities that you've served that you're now going to bring into your role as Chief Medical Officer?
Yes, so there's many challenges that we still face here in Australia and around the world, and one of them we've just been talking about, which is the issue of equity, making sure that everybody has access to high quality healthcare, no matter where they are, no matter who they are, and also not just access but also the outcomes of the healthcare experience, making sure those are positive for everybody as well. I think there are lessons to learn about how we strengthen primary care in Australia, how we introduce more multidisciplinary team-based care, which can be different based on geography or based on different priority populations of people and what their needs may be. I think there's lots to learn about integration between hospitals and community care, bringing the walls of our hospitals down, getting better communication when people are discharged from hospital, looking at models like hospital in the home, and reducing our reliance on people being in a hospital but still getting access to really high quality care. Lots of exciting areas of development in digital health and innovation. We've talked about telehealth, but artificial intelligence is having a big impact. I think we're on the cusp of seeing some really exciting changes in how we use genomics in day-to-day healthcare, looking at the electronic health records. Australia is one of the few countries that has a national electronic health record through My Health Record. And looking at how we can use that to improve the quality of care as well. I think there's lots of challenges in the training of the future health workforce, so yourselves and people who are watching this video as well. Are we training you with the right skills to meet future population needs? Are we training you in the right places to learn what you need to learn? And one thing that I've gathered through working with medical students throughout my career is that many of you will have multiple careers. You may spend some time working in a big city. You may spend some time working in rural and remote areas. You may spend some time working in other countries. You may decide to go and work with Médecins Sans Frontières or some other organisations, aid organisations, and your career will take you into all sorts of places that you never imagined. When I was a medical student graduating in 1983, I had no idea where my career was going to take me, and it's been a wonderful journey, and I hope all of you have the same wonderful journeys. I think the other big challenge is looking at the external factors on our healthcare systems, and the things which concern me the most are we prepared for the increase in the number of older people in our communities? And in a country like Australia with growing migration, do we have the health services to meet future population needs? Are we prepared for the impacts of climate change, and particularly the impact if we have climate migration starting to occur with people moving around because of the impact of environmental disasters or heat stress or the other stresses that come with climate change? And I think the other really important area is learning those important lessons from the COVID-19 pandemic as we prepare for possible future pandemics. And it's not just around having good infection prevention and control, even though that's incredibly important. It's also about looking at the inequities that COVID-19 shone a spotlight on, the populations who were most affected during COVID-19 in Australia and around the world. And are there things that we need to be doing to support healthcare for everybody, which brings us back to that issue of equity that we were talking about at the start.
It sounds like there's a lot of things that you have to consider before making any one decision. Like, if you could distill all your years of knowledge, be it in leadership, also working as a general health practitioner, into one phrase that most guided or impacted your decision making? What would that phrase or idea be?
Yeah, I think I think there's two words which are most important for me. One is care, and the care that we provide as individual health practitioners to the people who trust us for their medical care and advice, and that comes through. If you through your bedside manner, through your communication skills, through the extra mile that you go for looking after the people who come to you as patients, and the other one is trust. And one of the most important things that we have as doctors is the trust that the community places in us, and that we must never breach that trust. And it's important for medical students because you're in a position of trust already as young doctors, doctors in training, and you must always make sure that you don't breach trust, that you are ethical in the work that you do, that you maintain confidentiality at all times, and that you maintain your integrity because people are watching you. Even as medical students, people are watching the way you behave, they're watching your habits and your behaviours. I remember once when I was doing a stint working as a country doctor in a small country town, and one of my patients brought in her small child who sat on my desk and said, "We saw you running across the road and not crossing at the lights the other day." And I thought, okay, probably guilty. I said, "Well, I shouldn't have done that, should I?" And he said, no, you should always cross at the lights and cross the road safely. So I got a lesson from a 5-year-old on road safety, which also gave me a lesson that people were watching and watching what I was doing.
And what do you believe are some of the other important traits of a leader in healthcare that junior doctors and medical students can start to develop?
Yeah, so I think we are all leaders, and we all become leaders in healthcare, whether we're leaders of our local practice or the clinic where we're working, whether we take on leadership roles in our hospitals or with our colleges, or we work with government, whether we take other leadership roles in the communities where we work. There are many doctors who get involved in politics, for example, and other types of leadership roles. So, I think that building your skills as a leader starts early and getting some experience if you can. And I think for me, the most important thing about becoming a leader was actually being humble and knowing that I didn't know everything, and knowing that there is a lot to learn, and there is still a lot to learn. I still learn from colleagues. I still learn from others about aspects of medicine and healthcare. No one can know everything there is to know, and so being humble about that, and not being arrogant. We doctors sometimes get accused of arrogance. I think one of the most important things is not to be arrogant, and learn from each other and respect each other's opinion, and acknowledge that not everyone will see things the same way that you do. I mean, for me, my greatest teachers have been my patients. It's been the people who have trusted me for their care and advice, who've come to see me and have shared with me what it's like to live with the medical conditions that they have, and providing insights that I didn't have because of my own limited personal experience. But through your patients, you get the whole world opens up in front of you, and you learn about cultural interpretations of healthcare. You learn about the challenges of people who are older than you that they encounter with healthcare systems. You learn from people who've had different experiences through their lives. Some of my strongest teachers have been people living with disability who've been able to teach me about how they navigate the healthcare system and the challenges that they have. And, people will open up your eyes and tell you all sorts of things if you're open with your communication, if you're interested in other people. And, let's face it, that's one of the wonderful things about being a doctor is we get to the privilege of working with other people, and people share with us because of that trust and because of the care that we're showing. They share with us some of the most intimate challenges that they have, and provide us with the opportunity to learn more, and in doing so become better doctors for the next patients we see.
Yeah, I agree. I think in medical school, there's this kind of feeling that you learn about all these diseases in a textbook and you feel like you know a lot, but you get kind of like robbed of the opportunity to understand a lot of what the disease actually means for a patient.
Mm. Yeah, I mean, we have to know about the anatomy, we have to know about the pathology, we have to understand the diseases. But then the challenge is that different diseases present in different ways in different patients. And then you have people with more than one chronic health condition, and the interaction between those two conditions, and what is the impact that these medical conditions are having on this person's life, on their quality of life, on their ability to do the things which are important to them. And sometimes the most important question is asking that, what do you need to do that you are having difficulty doing, and how can I work with you or bring in other members of the team so that we can actually help you to achieve the things that you want to achieve? I learned very early on that there's no point creating a management plan which works for me. It's got to work for my patient, and we can work that out together. And it's a waste of time developing a plan which isn't going to work for that person, because they may nod and say, yeah, thank you very much, and then leave and go, I can't do that. That's not going to work for me.
Do you have any final encouragements or words of advice to medical students or junior doctors who are listening?
Yeah, well, look, I think this is incredibly exciting time to be training in medicine. And we touched earlier on the impact that genomics and artificial intelligence and digital technology are going to have on your future careers. And, you will practice medicine in ways which are different in many ways to the ways that I've practiced medicine throughout my career. But at its basis, so many of those important lessons remain about the care and about the trust and about being person-centred in the work that you're doing, and about working cooperatively and respectfully with other health professionals throughout your career, and using this new technology and new innovations, but using it in a way where you are conscious that any new innovation may bring great benefits, but may also bring great risks to our patients. So making sure that you're thinking about the safety and the quality of the care that you're providing, as well as getting excited about the possibilities of new technology. Don't let the technology become its own thing. Look at how is this actually going to help the person who I'm working with.
Well, thank you so very much for joining us today, Professor Kidd. I'm sure many of our listeners will agree that it's been fantastic listening to your insights from so many of your experiences, both clinically and in leadership. And it's been an absolute pleasure talking with you today. So thank you.
Thanks, Emily. Thanks, Sean. It's been great talking with you, and best wishes to you both on your future careers, and best wishes to everybody who's listening in as well.
Thank you.
Amazing. Thank you.
We'll clap.